Now we'll go and look at the warning signs, because then what do we have to do? Is it right to screen all patients? Well, the answer is probably no, because of the cost. More importantly, the safety factor. You don't want to screen patients who do not need the screening and potentially expose them to radiation or inconvenience. You would like to look for warning signs and identify patients at risk, and then proceed with the diagnostic testing. Well, what are those warning signs? Obviously, a family history of bicuspid aortic valve or TAD syndrome is significant. Families who have a history of premature sudden death that was never been proven by autopsy, it makes a very difficult group of family members and loved ones that really unanswers the question, because most of these patients, when they are seen in emergency room complaining of chest pain and dying as a result of that, they have been certified by the ER physician or family physician that they died of a heart attack. And this has been going on, and I think a lot of our cardiovascular death statistics are inaccurate simply because we don't know how many of these so-called certified heart attack death certificates are really not true, and they had no sign of heart attack at all. But however, we know patients who did go through the painful experience for the family of having lost a loved one, going through autopsy, but giving us a valuable information that these patients actually died of aortic dissection. So this is a red flag. Any premature sudden death in the family, these patients should be screened. How about family history of cerebral aneurysm? This is also another difficult area, because many patients with cerebral aneurysm present with a stroke. So how many of these are ischemic stroke and how many are hemorrhagic stroke? Sometimes we don't know. In a local community hospital, we certainly, if we have a young patient, which happens in a lot of these patients, die of massive stroke, that how many of them truly had cerebral aneurysm and potentially had TAD syndrome? This really needs to be carefully looked on. Coarctation of aorta. We know now that it is the most common associated congenital anomaly with bicuspid aortic valve. So all patients with coarctation of aorta, they need to be screened for TAD syndrome. Patients who had a previous aortic valve replacement, but they really don't know size of their aorta. Jim Velavier syndrome. He was never told that how big was his aorta. However, it was mentioned with a handwritten report that he had a dilated aorta. We really need to know any patients, but certainly any patients younger than 7 years of age, that they had aortic valve replacement, they should be ruled out for TAD syndrome. Patients who presented with chest pain to emergency room, very often they get workup for coronary artery disease, and they undergo coronary studies, and they end up having normal coronaries. And these patients are sent home either on tranquilizer, they're called being a little bit too anxious, a little bit too nervous, and chest pain is just a figment of their imagination, and they or some of them have been sent home with antacids. We know these patients should not be told that there's nothing wrong with your heart. They really need to be screened, and then we will can assure them and give them more accurate information. Also, other associated TAD warning signs are ocular abnormalities. Some of these patients have weak eyes. They are very myopic. They have history of detached retina. This is definitely a red flag. Patients can have abnormal teeth arrangements, palate abnormalities with a very high arch palate, spine abnormalities with scoliosis. They also have very delicate spine, musculoskeletal system. They can have pectus excavatum, which is a depressed breastbone, or equally they can have a protruding breastbone. Many of these patients we have screened, we have heard that they had a history of hernia repair, or they do have hernia awaiting repair. Many have symptomatic acid reflux disease, or so-called GERD. Flexible joints is a possibility in some of TAD patients. Not everybody has it. So is elastic skin, flat feet. All of these could be potentially help us narrow down the diagnosis. A few years ago, we distributed a poster to all EMS and paramedics to signify a patient who presents with chest pain could be counted as an acute aortic syndrome due to distended thoracic aorta. As we know, when a distended aorta is under higher blood pressure, can produce chest pain. They really need to screen these patients. This is really the bottom line of what and who and why and where and when of a patient with TAD syndrome. When they present with chest pain, they really need to go on to be screened whether they have a dilated aneurysm in their chest or not, particularly when the EKG is normal, when the enzymes are normal, and when all the coronary testing is negative. Well, as you can see in this picture, we have a team of miracle workers in this hospital, which I feel very lucky and fortunate to work with them. This picture was gotten at the time that we had a very high-risk patient survived and tested all of us. This was a patient that was told he had 90% mortality and was refused by surrounding hospitals, and he actually had arrested in the cath lab, and it really took a team of miracle workers, which they were all standing tall here, that made him survive, and he's a very happy man and has a very grateful family. However, we got to protect this team. This is just a sample of all of us who are sitting here and who are out there. It's our responsibility to protect them. Is there a TAD patient among these miracle workers? I really don't know. But could it be? Well, it's possible. If there is one, how can we identify it? How can we help them and protect them and make sure they would get the right test? They would get an intelligent interpretation and also be put on treatment why they don't need surgery. Or if they do need surgery, not to waste time and provide them with the safest procedure available. We have so much to gain and so little to lose by trying to think within the family what we would do for our own family that we would do for other people, how we can protect them, and how we can potentially be 99% safe. We will do the same thing.